Go whenever you're ready.
Great. Thank you very much, Madhu. My name is Daniel Margolis. I am the co-director for prostate MRI at UCLA, and I was asked to speak to you about imaging for prostate cancer. The background is complex. A study less than a year ago found that a quarter of men with low-risk cancer received scans that they probably did not need based on their overall risk assessment and medical condition. However, there are a number of high-risk men who do not get the scans that they need in order to plan treatment. And there are new modalities, such as MRI and PET, that are not widely used. So there's understandable confusion of what is appropriate imaging for patients. The considerations that your physician will ponder in terms of making a choice for imaging include whether include what kind of risk is the prostate cancer to this man. And this is based on PSA, the number and percent positive of prostate biopsies, and the grade of the cancer on the biopsy. So in large part, this decision is made based on the clinical parameters of PSA biopsy, but also based on the man's age and overall health. So as you might understand, a younger man who's in really good health has a much higher chance of surviving longer than a man who's in generally poor health, where investigating cancer may pose as great a risk as treating it. So imaging for staging, it's primarily high-risk men more than low-risk men. It can also be used to localize cancer within and around the prostate in order to guide the choice of therapy. There are a number of imaging choices that your physician has available to determine this. In order to image the prostate and surrounding tissue, your physician can use color power Doppler ultrasound, wave ultrasound elastography, and magnetic resonance imaging. To evaluate the spread of cancer, in other words, to look at the bones and lymph nodes, your physician can use computed tomography, nuclide bone scan, or positron emission tomography. And again, you can also use MRI. I'll start by discussing ultrasound. These images, courtesy of Duke Bond, in the upper left, show a grayscale image of the prostate with hypoechoic or dark area on the left side, delineated by the plus sign, or what we call electronic calipers. And you can see arrows are pointing to areas of increased vascularity on color power Doppler ultrasound. Grayscale ultrasound can be used to identify cancer, but can't discriminate cancer from benign changes. So in an otherwise completely normal prostate, cancer may be conspicuous, but many times the prostate isn't completely uniform because of prior inflammation or prostatic hyperplasia or other changes in the prostate. Abnormal blood supply, a Doppler signal shift is seen with prostate cancer on our Doppler ultrasound. That gives rise to that reddish appearance that you saw on the previous slide. What detection is by institution. If you view the scholarly literature, you will see that there are some sites that have shown a significant increase in their biopsy yield, where sites have not seen the improvement in their biopsies. And this relates both to the skill and quality of the power Doppler ultrasound, but also in the patient population. Come across literature that mentions the use of ultrasound IV contrast dye, which has been shown to improve biopsy yield. However, the IV contrast dye for ultrasound available in the United States is approved for use in the prostate. It's only approved for echocardiography of the heart. In general, it's only used barely for research purposes in the United States. Echocardiography is a new and probably experimental technique. You can see on these images, which are from one of our premier radiology journals, the American Journal of Röntgenology. The left is a whole mount specimen, so a cut section through the prostate where a pathologist has outlined the tumor. And then on the upper right, you can see a grayscale image of the prostate. And you don't really see any cancer on that image. But if you look on the lower two images, you can see there's a deeper blue color which relates to the sonographic characteristics of this cancer. Elastography is the measurement of stiffness of tissue. Are generally stiffer than normal tissue because of the action, so there tends to be swelling. It also tends to have more densely packed cells. So oftentimes a surgeon will be able to detect the presence of cancer during surgery based on touch alone. Electric techniques measure shear wave tissue properties of ultrasound using Young's modulus. You can evaluate elastography with MRI. It is difficult to do this in the prostate because of the difficulty in sending the shear wave during the MRI examination. It has shown to improve biopsy yield for detection. NA identify men who do not need biopsies by virtue of the absence of areas that look stiff. How this is unknown. There have been no series of evaluated to determine whether or not it can exclude need for biopsy. So this is a very young technology, but very promising. To consider prostate MRI, that to remove the prostate surgically versus the use of radiation or chemotherapy is based primarily on the clinical factors that I mentioned earlier, PSA, biopsy, and physical examination. But reliably tell if the cancer has spread beyond the prostate or on which side. Biopsies also can often do this the most aggressive tumor in the prostate. So breast cancer has a mammogram for screening, colonoscopy, but don't have a screening test that looks at prostate for cancer. There's no manogram, courtesy of Admatec. How does MRI work? There are 4 components. One of it looks at anatomy, looks at the chemical concentrations in the prostate, looks at cellular density, and fourth looks at blood flow. Resonance imaging uses magnetic pulses to generate images of tissues in the body. Imaging based on inherent magnetic properties of tissue to delete anatomy or functional parameters, such as blood flow, cellular packing and disorder, or concentrations of various chemicals. MRI of the prostate generally consists of 4 components, as I described earlier. The T2-weighted imaging is used to look at prostate anatomy. Weighted imaging evaluates the degree of cellular packing and disorder. For dynamic contrast imaging, looks at blood flow. Electroscopic imaging measures the levels of chemicals involved in normal prostate function and transformation into cancer. So what do we look for with prostate MRI? It looks at location and amount, and also the aggressiveness of cancer in the prostate. It also for spread of prostate cancer, the surrounding tissues such as seminal vesicles and neurovascular bundle, the lymph nodes, and bones. So prostate MRI, the holy grail of prostate imaging, it is motionless on a table for about an hour. The needles involved are an IV for contrast injection, and we inject a drug called glucagon that prevents cramping. And in contrast, are superior to ultrasound or CT, and completely safe except in rare cases, claustrophobia, or kidney failure. And even in these cases, we can usually perform prostate MRI safely. So it has a lot going for it. But whether or not it truly is the Holy Grail remains to be seen. In terms of anatomic characterization, can MRI techniques, combined with the optimized signal-to-noise ratio achieved with an endorectal coil, provide high-resolution imaging of the prostate. These images are you look at the area around the prostate, invasion through its capsule into the seminal vesicles. So here of anatomic imaging of the prostate. The red arrow shows a dark area in the prostate that appears abnormal compared with the normally bright area of the surrounding prostate. And on the bottom image, we can see that this dark area is extending upward into the seminal vesicles. The group is identified dots on the outside of the prostate that represent the neurovascular bundles. And this is important to delineate because invasion into the neurovascular bundles means that treatment would necessitate sacrifice of that neurovascular bundle. So what extracapsular extension? With this image, you can see that this irregular dark area has extended into the tissues on the side of the prostate. So that's fairly obvious. But there are other signs that suggest more subtle or minimal extracapsular extension. So on the image that we saw before, you can see that the dark area extends to the edge of the prostate here. Irregularity or blurring of the capsule, which also suggests minimal extracapsular involvement. And again, it's important to determine whether or not this extends to these dots on the outside of the prostate because it suggests involvement of the neurovascular bundle. Endoscopic imaging measures chemicals involved in normal prostate function and cancer. So it can determine the concentration of some chemicals, but the still resolution is not as good as anatomic imaging. We sacrifice spatial resolution for chemical resolution. Cooling is a marker of cellular proliferation and is increased in cancer. It's only relatively low. Citrate is a component of normal healthy prostate cells and is consumed during transformation into cancer. And line graphs show the relative concentration of these chemicals. Here, example, an abnormal line graph where choline is much higher than citrate. So where you can see that in this image of the prostate, there is sort of wedge-shaped area of low signal on our left side and sort of less well-defined low signal area on our right side. A spectrum that corresponds to the area on the right does elevated choline and depleted citrate and confirms the presence of cancer. We see the normal appearance of high level of choline, or citrate rather, and low level of choline. This most likely represents old inflammation. Diffusion imaging helps evaluate the degree of cellular density. Cancer cells are densely packed than normal healthy prostate cells. It restricts the free wall motion, which we can detect detect MRI. MRI is a map of free water motion, also known as Brownian motion, to localize densely packed cells in areas of inflammation which may already be dark. So we use different weighted imaging similar to spectroscopic imaging to identify if an area is suspicious on the anatomic imaging. So you see this very subtle low signal area on our left side, illustrated with the red arrow. It doesn't look that suspicious. However, on this color map, we can see that there is focally restricted diffusion that corresponds to that area. The restricted diffusion is colored orange or red on these images, and this confirms that this isn't simply inflammation, but is actually cancer. So imaging for blood flow takes advantage of the fact that cancer requires a rich blood supply. Tumors secrete chemicals that grow in blood vessels. MRI tracks contrast dye and identifies areas of abnormal blood flow, similar to color-powered Doppler ultrasound. Imaging can generate snapshots, and then we can use complex computer models to detect parameters of blood flow. So, for example, we see that there's dark area on both sides of this prostate and the peripheral gland. On the image, we can see that there's restricted diffusion. So that suggests that the left side is actually cancer and not simply inflammation. And this is confirmed with the presence of this markedly abnormal blood flow. So, is this truly holy grail, or is it just another drain on healthcare? This is not a straightforward answer. Prostate is probably not one or the other, but does have specific uses. It's for guiding biopsies, for and staging for moderate risk disease, and also if minimally invasive therapy is planned, and follow-up. So for guidance, in case of a rising PSA and negative biopsy, a second look is often warranted. Identify the most suspicious area in the prostate, and biopsy can either be done directly under MRI guidance or MRI ultrasound image fusion under ultrasound guidance. So what's the best way to do the biopsy? Well, as you might know, MRI has not been proven to exclude significant cancer. Although it's sensitive for cancer, it's not specific, meaning if you don't see cancer, that doesn't mean that it doesn't exist. Looking into new techniques to determine whether or not MRI could be used, but currently we don't feel that the technique is optimized enough. Ultra-guided biopsies are generally systematic and based on imaging findings, except in some places where color-powered ultrasound is used to guide them. MRI biopsies target suspicious areas directly with image information, but MRI machines cost a lot more than ultrasound, and time on the MRI machine is expensive, and so it makes MRI-guided biopsy an expensive position. We confuse MRI data with ultrasound, and suspicious findings on MRI can then be localized with ultrasound and biopsies. This can expand the advantage of image-guided biopsies to areas where MRI-guided biopsies are unavailable. And some sites, such as University College London, are doing the ultrasound-guided biopsy without sophisticated software, based purely on the knowledge of the location of the tumor and looking at ultrasound tissue characteristics. Surveillance, patients with low-volume, low-grade disease, MRI provides two advantages. First, it screens the prostate for areas that might be suspicious for high-grade cancer but were missed on biopsy. And it provides a baseline follow-up to look for subtle changes. So maybe instead of performing biopsy at each repeat follow-up, you could skip some of the biopsies and do MRI instead. Planning, MRI provides two pieces of information which are useful for surgery or radiation. One is the overall size and location of the prostate and cancer within it, and it looks for a spread of tumor beyond the prostate, especially into the nerve bundles, into the bladder or rectum, or to lymph nodes or bones. MRI for a rising PSA after treatment. Rising PSA after prostatectomy suggests recurrence of cancer. MRI is sensitive for detecting this recurrent disease, both in the solar radiation bed, in bones, and lymph nodes. And I can also detect recurrence in the radiation therapy field. Obviously, this is first detected with a rising PSA. But we have an elevated PSA, especially if it's above 1, we can often find the area of recurrence. The question is usually, do we need to use the endorectal coil? Endorectal coil does improve image quality about tenfold. Usually only necessary to characterize a prostate capsule. So you need to know if the cancer is invading into the capsule or neurovascular bundle, then we do need to use the endorectal coil. And it's also necessary for spectroscopic imaging. Just for detecting cancer, such as biopsy planning, it may be needed. Since in lymph nodes, we have a number of choices. The CT and bone scans is primarily reserved for intermediate to high-risk men. Were established over a decade ago and remain largely unchanged. This is a table from a 2007 article by Hedvig Ritzak, who is probably the national leader in prostate MRI at Sloan Kettering. What her group found is that the guidelines are basically men with a PSA over 10 nanograms per milliliter, or Gleason score greater than 6, meaning Gleason score 7 or above. And which test to use varies based on which of these series you're looking at. Reserve imaging for PSA greater than 20. Here's an example of a CT scan. You can see here we've identified a lymph node. It'd be difficult to distinguish this as a lymph node from surrounding structures. Fortunately, we look at more than one image at a time. That helps us identify lymph nodes, which are spherical, from blood vessels and intestines, which are tubular. CT is basically a 3D X-ray. It sends large lymph nodes and for bony abnormalities. It's not a threat of cancer to small lymph nodes. So very early on, but the lymph node has enlarged, CT is relatively insensitive. And then the non-specific findings on CT when it comes to changes in the bones. So sometimes we can be fairly specific as to whether or not changes are cancer benign, but there are some times when it's equivocal. Often want to use IV and oral contrast because this help us distinguish lymph nodes from, for instance, loops of bowel and blood vessels. He doesn't really characterize the prostate itself. It's you look for bones and lymph nodes. So the CT scan, what would be treatment planning, such as external beam radiation therapy or monitoring. We use PSA monitoring, but when there's an abnormality on the follow-up PSA, then imaging may be warranted to determine why. It can be used to confirm that there's no obvious disease outside of the pelvis. So, if surgical or radiation therapy is planned, you have to make certain that you are treating old disease that you can detect. In some cases, to confirm bone scan findings. Radio scan results in images like we see here. This is actually from that same AGR article. 99 stable methylphosphonate is a radioactive compound in areas of bone turnover. Your body's response to cancer, actually the cancer itself. There are other tumors that are not or don't show up on radionuclide bone scan. So, kidney cancer often does not show up on scan, but prostate cancer nearly always does. As you might imagine, only sensitive for bone disease, so it would not detect lymph nodes. We sometimes see false positives in diseases, such as arthritis. We can usually distinguish whether or not it's versus a benign process based on the X-ray. So, because T is a three-dimensional X-ray, the combination of bone scan and CT is very powerful when one may be equivocal. It provides a relatively fast and very complete study of the entire skeleton. So, consider a bone scan, treatment planning, which is external beam radiation therapy, in order to make certain that if there are bony metastases, they are included in the radiation field. In addition, with bone pain, if you're going to use samarium or strontium, these are radioactive compounds taken up in areas of bone turnover, which can treat bone metastases. But again, PSA is generally cheaper. And then to confirm that there is no bone disease outside of the pelvis. So if you already have a CT or an MRI of the pelvis, and it does look like there may be some enlarged lymph nodes, it is prudent to make certain that there are no bony metastases outside of the pelvis. Most importantly, with known prostate cancer, when there's pain, it's difficult to determine is this cancer pain or arthritis pain or muscular pain. Can be very confusing, and the bone scan can resolve this. Or positron emission tomography, PET scans are often used to detect spread of high-grade disease. Less good for prostate cancer than other cancers, especially for low-grade disease. The current PET agent is fluorodeoxyglucose. It's an analog of sugar, and I'll go a little more shortly. There are experimental agents which show promise, but not been proven useful in large studies, in part because they tend to be difficult to produce large amounts with high quality. There's the potential of doing a bone scan with a fluoride agent that shows up on PET. Is also very promising. So again, conventional PET agents use an analog of sugar, slight increased metabolism of cancer. Prostate cancer generally prefer to use other metabolic agents and not sugar. As you might know, it has cell surface receptors for testosterone. So one potential PET agent is a mimic of testosterone. PET agents identified specifically for prostate cancer. So here, that image again of a comparison of testosterone and glucose labeling on PET. And is that some are equally well seen. Others are more obvious on the testosterone scan, such as this lesion in the neck. So the testosterone scan may be more sensitive for prostate cancer, but it is still considered experimental and not available for clinical use. What about fluoride? So we saw on MRI, choline increased in prostate cancer. A compound, 18-fluorocholine, is concentrated in high cellular turnover, and just plain fluoride is taken up in bone lesions. So here's an example of CT on our right side and PET on the left side. And the regular choline, the fluorocholine choline is this image, and the plain frame is on the bottom image. What we see is area on the CT scan, which corresponds to the bony pelvis, was bright, would be suspicious, but it doesn't show up on the choline scan. So in fact, it turns out to be benign or false positive on the bone scan and on the CT. However, you can see that this area here in the pelvis posteriorly shows up on both scans and is therefore suspicious for cancer. And additionally, you can see that there's this dark line here sort of in the center of the pelvis. We can't see anything corresponding on the CT scan. It probably corresponds to the prostate cancer itself. What about its imaging? Has superior sensitivity to CT for bone metastases, but only very slightly. And again, it can be abnormal with benign changes as well. MRI is equally sensitive to CT for lymph nodes. But as you might know, MRI is more expensive than a CT scan, and it takes much longer to acquire the scan. It also currently still relies on enlarged lymph nodes. There is a contrast agent that has been used to look for micrometastases to lymph nodes. It was not approved. There's a new version of this agent which is under review. These are courtesy of Mukesh Harisinghani from Massachusetts General Hospital. Here we see a benign lymph node. So here's before we give the contrast agent, and here's after on our right. And you can see that the lymph node goes from bright to dark. So that's a sign. Lymph node, meaning cancerous. And see that after we give the contrast agent, this node does not change. You can see another lymph node posterior to it that does change. So this is a benign lymph node posteriorly, and on the top where the arrow is a malignant lymph node. In fact, in this image here, you can see the speckled appearance of the lymph node, and that suggests partial infiltration. So there's some cancer in the lymph node, but most of it is still benign. And this is important for detecting micrometastases. So what points for imaging? Technology has many options for imaging prostate cancer. We would choose depends on the overall risk level and treatment. Better for evaluating the prostate itself, such as ultrasound and MRI, or more useful for whole body staging, such as CT and bone scan. That concludes my talk for today.
Oh, sorry. Thank you for that presentation. I think Jan has a question, right?
Yeah, hi, Dr. Margolis. This is
Hi.
Jan. All right. How are you?
Good. How are you?
I'm good. Can you explain for us, you did a PET scan, which is really interesting because it's not, usually reimbursed by Medicare, but there currently is an NOPR. Can you explain what that is and how that might make it available? And is UCLA part of the NOPR?
So the National Oncologic PET Registry is a it's a national compendium of sites that will use PET scans for cancers where it is generally thought to be of lower yield, meaning less useful, to determine exactly how good or how not good it is. I know that UCLA was part of the NOPR. I don't know if that is still ongoing. We do PET scans for prostate cancer, but very rarely. I'm fortunate to work with our nuclear medicine specialists in interpreting PET scans because so many of them are PET-CT now. And because I also read CT, CT. We often do this in conjunction, but I really see patients for prostate cancer. We occasionally have patients that have choline for PET scans. Now, because we are a relatively large research institution, we have our own cyclotron and can use the carbon variant of choline for PET scans. It's a little better than fluorocholine because carbon-13 choline is chemically identical to choline in your body. The difference is that it's radioactive and shows up on PET scans. And this is very promising, but it's not reimbursed. And although we can use it under investigational review board approval, it's relatively expensive, and we do not currently have a research grant to reimburse for it. So it's generally not commonly used.
Cost the patient. Do you know?
I'm not sure what the cost is. It's thousands of dollars.
Okay.
But I can't remember. I think it was about $2,500.
Okay.
What was this 6 or 8 years ago? I had a PET scan 6 or 8 years ago and it was covered by Medicare.
So PET scans for prostate cancer using FDG may be covered for the NOPR. Other cancers for which it's nearly always covered for staging and for therapy follow-up. So, for instance, lymphoma, melanoma, colon cancer, lung cancer, we commonly use PET scans to evaluate these cancers. Few of them, with the exception of colon, have a serum marker, meaning a blood test that we can use to follow them up. So colon cancer has CEA, and cancer has no marker. Breast cancer does a reliable serum marker. Lymphoma and melanoma have no serum marker. So you have to use imaging to follow them up. That's the reason why we're more likely to use a PET scan for other cancers compared with prostate cancer.
I had mine, they said it was, it went down to 1 centimeter. So
the resolution of PET scan has actually improved quite a bit in the past few years. With some new technologies, there's, I'm trying to remember the name of it, not shutter speed, time of flight. There's a time of flight registration algorithm which has gotten the resolution down to 2 to 3 millimeters. Unfortunately, it's still relatively unreliable for things smaller than 5 millimeters, and it's a consideration of what we call contrast to background. Contrast to background is a similar concept to signal to noise, a way of describing how obvious something is on an image. In this case, it depends on how much brighter the abnormal thing is compared to the surrounding area, or in this case, normal tissue. Because prostate cancer does not take up FDG as avidly or as strongly as other cancers, it has poorer contrast to background, which means it has to be larger before we can detect it.
just curious, I think I had a PSA of 7 when they did this CAT or PET scan. It was either 6 to 8 years ago.
Yeah.
Couldn't find anything. Timing. Now I'm 8 years later, and they still don't know where it's at.
Yeah. With PSA less than 10, and even with a PSA less than 20, we often will not see anything on an FDG PET scan. The reason is that FDG PET actually identifies the most aggressive kinds of prostate cancer. and intermediate level of aggression may not take up the FDG strongly enough to see it.
Well, I'm going to find out Friday when my PSA will be 24.
Yes, in that case, unfortunately, there's a good chance that we would see something. For sake, I hope that whatever it is treatable. But that's one time where PET can be very useful because it is a survey of the entire body, and so if it spreads to, let's say, a single area in the lung, you find that with a PET scan.
I got you. Well, I'll be asking a lot of questions when I see my oncologist on Friday.
It's important to stay invested in your care.
Very much so at this point in time. Since my overall health, my doctor says that you're good for 5 years.
Yeah.
Did you have a question?
Yeah, hi, Dr. Margolis. Another great talk. Thank you very much.
Oh, thank you.
Question has to do with the minimum PSA to make MR useful after a recurrence after radiation or prostatectomy.
In general, we don't see anything with a PSA less than 2. There are some cases, we don't see a lot of patients to begin with, and with a PSA between 1 and 2, sort of iffy whether we would see anything. Even some cases, with a PSA greater than 2, we haven't identified anything clearly suspicious. But because of the changes that go on in the tissue, in radiation, or in the surgical or radiation bed, it's harder for us to identify smaller tumors. So there's a lot of interest in the use of MR-specific contrast agents, and also in the use of specific PET agents. This area of great interest, but the progress is coming slowly.
Aware of the publications by Dr. Myers about what they're doing at the Sand Lakes Imaging with ferriheme contrast?
Heme is a contrast agent that seems similar in composition to Combidex. Combidex is the name given to the contrast agent that was proposed for MR lymphography and was not approved. However, the chemical composition of ferriheme is slightly different. And we don't have a body of literature that gives us a good sense of what we call the receiver-operator characteristics, or how sensitive and specific it is for detection of cancer. So there's a concern that maybe cancerous lymph nodes will take up the contrast agent and give you a false sense of security, and there's another sense that maybe it wouldn't get taken up uniformly in lymph nodes, and then you might overestimate the burden of disease. So I think it deserves investigation, but without direct investigation of ferriheme itself, which is different enough from Combidex that I don't think we can use the Combidex literature. I'm wary of base management on something that I might see on a ferriheme and scan. One could consider doing is, if you see lymph nodes that look abnormal on a ferriheme scan, is then do a targeted biopsy. That might be a useful way to use ferriheme. But I am cautiously optimistic with the emphasis on the use of ferriheme as an MR contrast agent. I'm really hoping that this new version of Combidex is approved soon, and the whole point is moot.
Oh, there's a new version of Combidex being investigated?
Yes, I am not certain whether or not it's been submitted to the FDA yet. There's the whole once bitten, twice shy phenomenon. But I think it's actually a different company that bought some of the technology that's going into developing this new contrast agent.
Is Barentz that's doing that?
He would be one of the investigators. We haven't been given the contrast agent for prostate cancer, but there are trials ongoing at numerous sites in this country and abroad.
Okay, does anybody else have questions? I don't see any on our panel on the screen, but feel free to jump in if you have one.
I have a question. Dr. Margolis, how long for prostate MRI, how long after radiation or cryo would you need to wait to get a sensitive enough MRI because of what changes were there?
Actually, a very important question. After biopsy, we like to wait at least 6 weeks because the blood products can confuse the images. With perfusion and diffusion scanning, we can often tell if there's an area that's suspicious, but the blood products can distort the image enough that you sometimes have to grade an area as equivocal. Of course, that's always very concern for the physician and the patient. After cryo, it's a very interesting question. Cryo results in fairly pronounced changes in the prostate that can be seen evolving for over a year. However, the treated area generally becomes fairly uniform. And we don't have a lot of data on the MRI after cryotherapy. The University College London group is looking at their population of patients that they are treating with HIFU, high-intensity focused ultrasound, which also is a chemical treatment for prostate cancer, a focal therapy. But I don't think they've seen a significant number of patients where they found a second tumor. Obviously, the untreated part of the prostate is very easy to screen with MRI. The treated part is a bit more complicated. And what we look for is basically symmetry. But my guess is because this is a relatively new area for us, if we saw something abnormal, it would probably prompt a biopsy first and not going directly to therapy.
What about your seeds plus radiation?
So the permanent seeds or long-term brachytherapy can distort the MR image. The radiation itself distorts the appearance of the prostate. It changes the signal characteristics. We've seen a number of patients, a large number, but maybe a dozen at this point, with seeds that we've scanned. We haven't seen any obvious large tumors, but these patients tend to be followed fairly closely, and we often get them when the PSA is barely 1. So the fact that the PSA is usually fairly low when we see them, plus the fact that there are a number of changes to the prostate, not the least of which is the signal degradation from the seeds itself, where we haven't seen an area that we know is recurrent. There are some areas where it's suspected, but I don't know that any of them have gone on to biopsy yet.
Anyone else?
Very much. Her husband actually was PSA over 7,000.
I have just one more question. I'm sorry, but can you help us understand, with going back to PET scan again, the difference between F18 and FDG18? Because those are the two
Yes.
PET scans in the NOPR, and at first glance they look like they're the same or very similar to the the untrained eye.
It's that DG that makes all the difference. So
Right.
F18 is pure fluorine.
Okay.
It's chemically identical to what they put in toothpaste. And the reason we put it into toothpaste is because it strengthens bones. It gets incorporated into bones, and it makes them stronger. So where there is an area of bone turnover, it will be incorporated much more quickly. So if, just like with a regular bone scan, methylene diphosphate, where bone turnover, F18, fluorine, pure fluorine, will be taken up very quickly. And because of the improved resolution, including imaging characteristics of PET, a lot of people feel that it's just a much improved bone scan. It also seems to be more specific for cancer than traditional bone scans. FDG, fluorodeoxyglucose. So it's still fluorine, but it's fluorine that's been attached to sugar. Basically, you take a regular sugar molecule and you swap out one of the hydrogens for a fluorine. And chemically, it's nearly identical to sugar. It has one unusual characteristic, and that is the chemical compound that's responsible for importing the sugar into the cell cannot then export it back out. And so it gets trapped inside cells. So cells that have a metabolism and use sugar will take up FDG very quickly. So fluorine 18 is a marker of bone turnover. FDG18 or 18FG is a marker of increased metabolism, and is not specific for bones. It's anywhere in the body.
So the FDG18 would be more appropriate for a patient who had some risky features such as hormone refractory or high glycemic.
Yes, especially if the PSA is very elevated, or if they're concerned that the cancer has de-differentiated, meaning become so aggressive it doesn't act like prostate cells anymore. And in those cases, it's more likely to take up FDG.
F18 is a probably more sensitive bone scan, basically.
Yeah, F18 is basically a better bone scan.
Okay. Thank you for that.
You're welcome.
Are there any more questions from anyone?
The status of insurance reimbursement for F18 fluorine.
NPR is reimbursing for recurrent disease or restaging,
yes,
but not for newly diagnosed.
It's complicated. It changes every so often. We have a further wrinkle here at UCLA. Although we have F18, there's a local restriction on its use here. Last I heard from my class in nuclear medicine is that they were not able to get exception for clinical use. And I don't know when that's going to be lifted. So I hate to admit it, we have fluorine 18 here at UCLA and we can't use it.
Is it something specific to your state, to California, or is that
to UCLA itself?
Okay.
And in fact, I don't even know if it would apply at our Santa Monica campus, although I think it would apply at Santa Monica, but for instance, it would not apply to UC San Diego or UC San Francisco.
This is probably the worst one for our business. The other side was that more on what we want.
Thank you, Dr. Margolis, for that talk. If there aren't any other questions, we have all of announced the members.
Another 5
And
Hello?
scheduled the 26th, and we'll be sending over some more details of that. As usual, we're going to send out shortly. Be in Los Angeles this weekend. We have our Dash for Dad race for prostate cancer with zero on Saturday at Dockweiler Beach. And I think that's about it. Thanks again for the great presentation. We appreciate your time.
Thank you for your attention.
Have a good one.
You too. Take care.
Bye-bye.
Bye.
Thank you. Those are all people leaving us. Is it? You heard before, people coming in.